Great. So come back. So my name is Brian Wishart. I am a pediatric physiatrist that works at Mass General with Dr. Eichler and Katie Becker in the clinic there. We have started sort of the end of last year. We put in for a clinical practice guideline on the symptom management and documentation of CTX. So I'm just going to kind of go over what our aims are and what our goals for this clinical practice guideline are. We were hoping to have some numbers and some stuff to present today, but got a little delayed with COVID and everything. But we've made some pretty good headway over the last month and a half. So we're kind of catching back up. So the aims of this CPG are really to expand our documentation of what symptoms are presenting and when they're presenting, and kind of what the numbers for each of these types of symptoms in CTX are. There was a previous literature review that came up through about 2016, and since then there's been quite a number of papers. So we are expanding the literature review and have completed that from 2016 through the end of 2019. Initially, it brought us about 66 papers, and then after some exclusion criteria, we cut it down to about 45. So we're now in the process of going through those papers to pull out the information, but I think we have a nice number of papers to do. The other thing that we're trying to do with this is sort of expand the symptoms that we were looking at. So we'll go over some of the previous ones from the previous papers, but one of the main things after talking with families and talking with the community is really some of the psychiatric symptoms that come with this disease, and trying to document when they come out and really break down them to a little bit more of a granular look, and see if we can see how exactly what is presenting and when, and whether there's some things that come out maybe earlier on in the disease process that we might be able to treat and identify early on. After that, we're hoping to go through the management and see what's out there, see what these patients are doing and what they're getting and how they're responding to it. I'd like to do this for both the neurologic as well as neurologic, and we'll see what's in the literature, but hopefully some of the psychiatric symptoms as well, and break down what medications these patients are getting, what type of therapy they're getting, and go through and document that as well. So we've been really fortunate to have some great families and working with us on the work group, and they've really provided some invaluable input in terms of what we're looking for and what symptoms they're seeing in their families and their patients or their family members, and being able to add this into our symptom review and our chart review to make sure that we're being complete with it. And so some of the stuff that we hear is that a lot of the symptoms early on are fairly vague, and that these severe symptoms that are leading to diagnoses don't come until much later. And we see that with the diagnostic kind of timelines being much later into their 30s and that sort. But sometimes, early on in childhood, there's issues with some cognitive declines, some psychological problems, behavioral issues, learning disabilities. And we're going to see if we can pull some of this out as we go through. So when we were going through this and talking about where we were going to start and what we were going to be looking at, one of the things that we really wanted to make sure we put in from the beginning is that we were focusing on what the gaps in our knowledge were. There are a lot of papers out there that have put out kind of individually this part of CTX, and trying to bring all of that together as one whole look. But while we're doing that, really saying, what are we missing? What are the things that we need to make sure we address as we move forward with further research? And doing that from the front end of our review. And so we'll go through and try to go through this comprehensive review of symptoms and add in some of the ones that haven't been done before. And then as well as the strategies for management and the different options. We're also going to try to expand our case series that was done in the previous review. So there were about 5 patients previously. I think we're up to 8 or 9 patients now in our clinic. And so we're going to try to expand our case review and go through those patients as well. So these are the symptoms that we're looking at as we go through. We've broken it down into neurologic, non-neurologic, and then psychiatric symptoms. Many of these were on the previous review that was done. There's a few that were added in, such as the tremors and ADHD on the neurologic side. Psychiatric, we really broke out. So initially it was just behavioral changes. And so we're going to see if we can break that down and see exactly what's going on and document when we're seeing this in these patients. The non-neurologic aspect of things, we've added a few things in, such as exercise intolerance and fatigability, which came out of talking with some of the families. Osteoporosis has been reported in literature in the past, so we're going to see if we can pull that out a little bit. And then we really talked about some of the gaps in the literature that we weren't really seeing, that we want to see if we can try to identify or at least start the discussion. And some of that has to do with, you know, different dystonias and different movement disorders, sialorrhea, and bowel and bladder dysfunction, and see if we can document anything that's out there. So these cumulative incidence function graphs are really how we're planning on analyzing the data again. This was from the previous one, which, you know, looks at kind of best case, worst case, earliest onset, latest onset possibilities. And that's just due to kind of inconsistencies in how the literature is reporting it. So if they were to say adolescence, we have to pick a timeline for that. And so these graphs just change a little bit based off of what's reported. But we'll look at them similarly and see if we have, you know, the same data and try to add in some numbers to the amount of patients that we're looking at through this. These are the more common symptoms that we were seeing, those corticospinal tract symptoms. So spasticity, weakness, hyperreflexia, Babinski signs, anything that gets reported like that. We're going to look at gait difficulties. My background as a physiatrist, I do a lot of gait bracing. I'm hoping to kind of dig into this a little bit and maybe be a little more clear about what type of difficulties we're seeing, when we're seeing them. Is it secondary to spasticity? Is it secondary to movement disorders like ataxia and other things? And exactly what we're worried about. And then there's, you know, some of the less common ones that we see. And we'll try to correlate some of these with treatment as well as we go through. As you can see in the non-neurologic side, I think some of this stuff, one of the questions that we have and has come up with the family is what the reversibility of these symptoms are as we go through with treatment. And I think some of this may be related to whether there's treatment, because I think diarrhea is something that we all would expect to be much more common when we talk about CTX. And in the literature here, it doesn't seem like it is. And so I think we need to be kind of clear when we're reading the research and reporting back on exactly what we're seeing with this stuff. And then the psychiatric symptoms. As you can see, this was really the only thing that we saw in the previous one. It was psychiatric changes. It didn't delineate exactly what they were talking about or what they were seeing. I think we were missing some of the more subtle findings that we see in these kids. So autistic features are reportedly very common when you speak with the families, learning issues, attention issues, and some of those may be coming on much earlier that we could start identifying and thinking about, at least as we're going through, and may be helpful when we start talking about treatments for earlier and younger children to see if we're having effect. So the management is going to be another big part of what we're looking at as we're going through this. We're hoping to look at both medications, looking at the timing, the dose, responses that they're having, if these are helping with the symptoms that we're seeing and which symptoms they are responding to, and then if there's any adverse reactions. We'll obviously look at CDCA. We're going to kind of cursorily go through that one, but also looking at our psychiatric medications, other CTX-specific medications, and then tone management, anti-epileptics. We'll kind of go through the different ones and see how they're responding and how often they're being used in these patients and at what age. And then I'd like to look at some of the non-pharmacologic aspects of this as well. So what therapies are these patients getting? Are they getting them when they're early on in childhood through adolescence, and then are they continuing as they go into adulthood? Augmentative communication is something that I think has come up with some of our older patients as they have issues with their speech and speech production, and what's being used, if it's being used, and exactly what's been successful for them. And then what kind of bracing we're using. And then we'd like to look at the xanthoma treatments as well. And like I said earlier, one of the big things that we'd like to make sure we document as we're going through this is what symptoms, what things, if we're seeing in these patients, are reversible with treatment, and which ones are we going to struggle and we really need to work on management versus thinking about cure with certain treatments. And again, looking at those gaps in knowledge as we go through and making sure that anything that we're not seeing and we're missing, we identify, so as we move forward with different research, we can be complete with it. So our goals with this review, obviously we'd like to put together a medical CPG that really goes through the documentation and management strategies that we just over a few. Eventually putting together a family companion similar to the other CPGs that we're going through. And then I'd like to dig in a little bit into the physiatric interventions and see if we can talk a little bit about what spasticity management is useful. One of the things I've seen with our kind of AMN patients, and that is that there's maybe a little bit of a different response to some of our typical medications. in that disease, and it'd be nice to know if that's similar in CTX or different, if they respond better or worse, you know, which way it goes. Same thing with the gait difficulties, to really kind of look at some of the specifics of what we're seeing, and how that'll equate to what physical therapy, occupational therapy, what types of therapy plans we need for these patients, and what type of bracing may be useful and worthwhile in their time. And then finally, that psychiatric presentation, and seeing maybe if we can kind of break that out and potentially have that as its own aspect. So I have to thank Hunter's Hope and Anna and everybody for allowing me to work on this and giving me the opportunity to do this. And then Dr. Eichler has been invaluable in terms of planning and helping me kind of get this together. And our CPG work group has been awesome every time we meet. So hopefully we're catching up a little bit on time. Thank you.
Thank you, Dr. Wishart. And now we'll turn it over to Dr. DeBarber.
Well, thank you, Dr. Wishart, for that great overview of the clinical symptoms that may present in CTX as the disease progresses. I would also like to thank Hunter's Hope for the invitation to present an update on another systematic evidence review that's being performed. And we hope that this review will aid in the diagnosis and treatment of CTX, particularly in infants that may potentially be identified in the future through newborn screening. So I'd like to introduce you to the work group for this project. This project's being led by Dr. Shailesh Patel at the University of Cincinnati. And the work group consists of other experts in the diagnosis and treatment of CTX, including physicians, Dr. Austin Larson at the University of Colorado School of Medicine, and Bob Steiner at the University of Wisconsin. As well as Christy Piper and Dr. Patricia Hain, Deputy Director of the US Cochrane, Colorado Affiliated Center. And so my name is Andrea DeBarber, and I oversee the clinical diagnostic lab at Oregon Health and Science University that specializes in the biochemical diagnosis of CTX. So today I'd like to share with you, and so we're early in the process of generating the systematic evidence review. I would like to share with you the questions that the working group has developed for the systematic evidence review. But before I do this, I would like to take a brief detour to talk about the pathway towards newborn screening for CTX. And so it was back in 2014 that the first demonstration was provided that CTX newborn dried blood spots could be identified using liquid chromatography tandem mass spectrometry with detection of a 7-alpha, 12-alpha dihydroxy-4 cholesterol 3-ion biomarker. And then back in 2016, there was a meeting hosted by the United Leukodystrophy Foundation to discuss submitting CTX, nominating CTX for consideration for addition to the RUSP to the Secretary's Advisory Committee. And this was a meeting of researchers, physicians, patient advocates for CTX. And we all worked together to generate the nomination to submit to the Secretary's Advisory Committee. Back in 2017, also a very important paper from Fred Vaz's group in the Netherlands. And they demonstrated again that CTX newborn dried blood spots could be identified using slightly different biomarkers, a ratio between a biomarker called tetrylglucuronide and the Toro chenodeoxycholic acid conjugate. Back in August 2018, we went forward and we submitted the nomination to the Secretary's Advisory Committee. At the in-person meeting in November in 2018, the CTX nomination was discussed and the nomination was tabled until additional evidence could be provided to the Secretary's Advisory Committee. So in the interim, we've been working on generating some of this evidence. In 2018, my lab identified one of the main markers in newborn dried blood spots, the tetroglucuronide. The structure of this was confirmed, and the concentration ranges in untreated CTX newborns and adults was determined. And then just very recently, Mike Gelb's lab has published data from a large screening study looking at more than 32,000 Washington state newborns. And he showed that a putative CTX positive sample could be identified, very importantly, with a 0% false positive rate. So the method that we have of screening for the positive cases works very well. And as Mike Gelb mentioned in his talk yesterday, the New York State Screen Plus Prospective Pilot program is taking place in the fall of 2020, and CTX is one of the disorders that will be screened in that prospective pilot study. And also in the Netherlands in fall 2020, they're also performing a study to screen 20,000 Dutch newborns using tandem mass spectrometry. So in the Netherlands, the Dutch Health Council has advised adding CTX to the Dutch newborn screening program on availability of a suitable screening method. And so this will generate one of the main pieces of evidence that the Secretary's, or hopefully that the Secretary's Advisory Committee would like to see, and that's identification of a positive CTX newborn through a prospective pilot study. And so I wanted to touch on today some additional evidence that was requested by the Secretary's Advisory Committee. So although the committee recognised CTX as a medically serious condition that deserves thorough consideration, they had some other questions in addition to, wanting to see a positive identification of a newborn through a prospective pilot study. They would like clarification regarding what is considered a true positive CTX case with relevant biomarkers included and documentation of consensus among experts in the field. They would also like more evidence in understanding how screening can inform treatment and how early treatment can impact health outcomes. So today I'm going to share with you the questions that the working group has developed for the systematic evidence review. And we really wanted to design these questions to help answer the questions posed by the Secretary's Advisory Committee. And so our first question will be, what are the minimum diagnostic criteria to define a true case of CTX? And with a sub-question, are biochemical testing and genetic testing together sufficient to diagnose CTX? The second question will be, should CTX therapy be guided by genetic or biochemical disease markers? And sub-questions are, do specific CYP27A1 genetic changes predict outcome? And if so, do these warrant specific therapeutic strategies? The next sub-question is, do levels of biomarkers at diagnosis predict outcome? If so, do these warrant specific therapeutic strategies? Question 3 will be, what is the effectiveness of therapeutic intervention in CTX to prevent disease progression? With the sub-question, what is the effectiveness of therapeutic intervention to normalize aberrant biochemistry? And sub-question, if the biochemistry is not normalized, are health outcomes impacted? And should there be a specific biochemical target as the primary goal of treatment? Question 4, does timing of the treatment initiation, including pre-symptomatic treatment, impact health outcomes? With the sub-question, should clinical disease stage and patient age impact the choice of optimal therapy, whether monotherapy or combination therapy? And the final question, question 5, are current CTX therapies safe? With the sub-question, what are the reported adverse events and their frequency and severity? So, we hope these questions will help summarize the evidence requested by the Secretary's Advisory Committee. And as I said at the beginning of the talk, that they'll aid in the diagnosis and treatment of CTX, particularly particularly in infants that may potentially be identified in the future through newborn screening. So this protocol will be registered at the Prospero website. And finally, we would like to acknowledge the support from Hunter's Hope to make this evidence review possible. And only a few minutes over